Well, he needs no introduction, but Jeremy Freeman will talk about primary thyroid surgery. Thank you, Jeremy.
Thank you, Paulo. It's a great pleasure and an honor to be here in the Eternal City. Jayton Shaw was supposed to give this lecture and asked me to substitute for him. Unfortunately, he couldn't make it due to personal reasons, but we wish Jayton well. I'm going to talk about hemithyroidectomy versus total thyroidectomy for differentiated thyroid cancer. I think this is important to reiterate, and I'm not going to tell you anything new that you already don't know. This is not a fancy lecture on transoral or transcervical approaches or transanal approaches. I'm just going to talk about basic approaches from an oncological point of view and give you the best available evidence as to why we should do one or other operations. So this isn't working either. Oh, here we go. Okay, so that's me. I come from Toronto, as you may know. Here are my disclosures. So the late Ernie Mazzaferri gave me a couple of slides, and I'm putting these on in his honor. There are only two operations that I do primarily on the thyroid. I do a subtotal or hemithyroidectomy, if you will, and I do a total thyroidectomy. I'm a surgeon. I'm very simple. These are all the operations I do on the thyroid. So what are the logical reasons to do a total thyroidectomy? Well, to maximize outcomes of surgery for dysfunction. Let's put that aside for a second because we're not here to talk about hyperthyroidism or Graves' disease. We're here to talk about cancer. So to aid in the technical aspects of thyroid extirpation, to maximize outcomes for surgery for thyroid cancer, and to minimize complications. So in order to formulate a rational approach to the type of operation, we need to look a little bit into the available evidence. So what are the logical reasons not to do a total thyroidectomy? So when outcomes are not affected by doing a lesser procedure, clearly that's intuitive. You don't want to do a big operation for a small procedure. Blake Cady used to say, let the punishment fit the crime. Ashok Shaha used to say the same thing. So let the punishment fit the crime. If complications are higher, even though outcomes are the same or better, with a lesser procedure. Again, let the punishment fit the crime. Let's throw this aside again. For Graves' disease, I think it's clear nowadays that a total thyroidectomy is necessary for Graves' disease. You don't want to leave viable thyroid tissue behind because Graves' disease may reoccur. So the proponents of total thyroidectomy. Why do a total thyroidectomy? Well, the recurrence rates are lower, they say. It allows for better survival. It clearly allows for radioactive iodine administration. It enhances monitoring for recurrence with thyroglobulin. You can't do thyroglobulin if you have thyroid remnant there, although you can use it perhaps as a surrogate for recurrence. It addresses contralateral disease if that's important. There's no need for a completion surgery if adverse pathological features or nodes are visible on final pathology. In experienced hands, there's a low risk of complication, and we'll talk a little bit about that in a few minutes, given the explosion of thyroid surgery by surgeons in North America who don't do big volume. It allows less frequent monitoring with ultrasound, and surgery for recurrence is associated with increased morbidity. We know that intuitively, and I know that from my own studies. So what about the proponents of hemithyroidectomy? Well, the complication rates are lower. There's no question about that, but what is the evidence? We'll look into that in a minute. It's not required to have thyroid medication, so patients can use their native thyroid hormone. Patients have problems when they're given exogenous thyroid hormone. All the endocrinologists in this room will agree with that. It's sometimes difficult to control. There is an increase of osteoporosis when you don't have your own native thyroid hormone. In the low-risk patient radioactive iodine most of the time is not indicated. In fact, in our institution, we only give radioactive iodine about 10% of the time. A lack of remnant ablation limits the interpretability of thyroid globulin. We know that for sure. But at the end of the day, there's no strong evidence to support survival or recurrence benefit by doing a total thyroidectomy. So, if you cull the literature, you'll see a myriad of investigations and studies, and I'm not going to give you a laundry list and enumerate them here, but needless to say, there are major supporters for total thyroidectomy, and one of the major studies that's come out is the Bill study that's often quoted, but even that has its own flaws innately. Sorry. And then on the other side of the ledger, there are proponents for less than total or hemithyroidectomy, and again, there are many studies that support this, and Ashok Shah is sitting here in front of me, and there's a seminal study that I always quote that's come out of Memorial, where the investigators did a match pair analysis of total versus subtotal, eliminating all the extraneous variables and parameters, and clearly subtotal thyroidectomy is the treatment of choice for selected cases of thyroid cancer. Now, we have to talk about selected cases. I just want to mention Ernie Mazzaferri, the late Ernie Mazzaferri. Ernie was a very good friend of mine and a very brilliant investigator and a very persuasive guy. Ernie was the scion of the management of thyroid cancer, and his Air Force study influenced us in the management of thyroid cancer for decades. Unfortunately, and Ernie will back his own study up to the hilt if he were here, but unfortunately Ernie's study has major flaws. The basic premise of his study was that he took outcomes of a number of Air Force men and women who suffered thyroid cancer. And he looked at the various operations applied by various surgeons, various outcomes, and various treatments. And his conclusion was that the best treatment for the management of any thyroid cancer, be it 1 millimeter or 100 millimeters, was a total thyroidectomy, postoperative radioactive iodine, and lifelong thyroid hormone administration. The study was majorly flawed. This study had multiple operators on multiple cases of various stages with dubious outcome reporting. And this is the study on which thyroid cancer was based for decades. So let's look at the guidelines from the American Thyroid Association. Guideline number 35 says that less than a total thyroidectomy can be done, Brian Haugen, I don't know if you're in the room, but you guys are very clever in your wording, for nodules less than 4 centimeters. Now, can this patient have a less than total thyroidectomy? I don't think so. Can this patient have a less than total thyroidectomy? I don't think so. And there's the pathology on that patient. Can this patient have that? Or here's a patient I was introduced first in the ICU when she was intubated with a thyroid cancer that was giving her a superior vena cava syndrome. Can this patient have less than a total thyroidectomy? No. So you can't apply one paradigm to all comers. And here's that patient having a sternotomy for her thyroid cancer. Can this patient have less than a total thyroidectomy? Obviously not. Can this patient have less than a total thyroidectomy? For this patient, we had to do a total sternotomy because the tumor is going down almost to the stomach. So there are patients, yes, who you can apply less than total thyroidectomy, but others that you can't. So one has to be judicious in deciding which operation fits which patient. So let's look at the evidence. So here's a review of 889 patients by Ian Nixon from the Memorial. And without going through the various nuances of this study, if you look at the 10-year survival with respect to total thyroidectomy versus less than total thyroidectomy for these early cases, clearly less than total thyroidectomy is applicable. No question about that. And if you look at it versus size of tumor, again, remember those tumors that I just showed you. You cannot apply this paradigm to all comers. So here's another study using the SEER data from the United States. And again, if you look at the survival and recurrence curves, the disease-specific survival, which equals recurrence, the curves overlap. So if the outcomes are the same, let's not do such an extensive operation. I agree with that. If you look at, I need to go back here. If you look at this study, which was using NIS database, and look at complications from over 13,000 operations, clearly, the complication rate for less than total thyroidectomy is less than a total thyroidectomy. Now here's the Bill Moria study again, and you can use stats to give you whatever outcome you want, no matter how. It matters on how you input the data. So Bill Moria put the data in, and his study tells us that you should do a total thyroidectomy for all thyroid cancers. So how do we decide? And here is Bill Moria's outcome data. And if you read this very carefully, I needn't go through this with you, but clearly he has, his data indicates that the best way to do this is a total thyroidectomy for all comers of thyroid cancer. The latest one, and probably the most comprehensive study that I've come across, was one by lead author Julianne Sosa, where they looked at over 61,000 patients, and obviously their conclusion was that less than a total thyroidectomy, where applicable, is the operation of choice. But if you look at the quality of evidence pyramid, most of these studies, in fact, all of these studies, are not at the pinnacle, but are at middle or low-level reporting paradigms for thyroid cancer. So will we ever come up with a comprehensive study? The answer is no, because the outcomes are so good, and also the number of patients that have to be accrued to give a meaningful study is impossible. But we needn't have to look at that as much as this. These are two studies on cost-effective analysis of total versus subtotal. And if you really look at all the cost-benefit ratios and cost-effective analysis of thyroid cancer across the board, the proponents of total thyroidectomy win hands down, because less than total thyroidectomy costs more to do in terms of patient follow-up, repeat ultrasounds, repeat FNAs, patient visits, cost to patients, cost to the healthcare system. So from a pure financial, fiscal point of view, total thyroidectomy is a better operation. And in this day and age, when we have fiscal responsibility, we must look at these studies. So at the end of the day, what did the wise people at the American Thyroid Association do? They told us that total thyroidectomy is the operation of choice for nodules greater than 4 centimeters, but for nodules between 1 and 4 centimeters, less than total thyroidectomy is an option, but total thyroidectomy also is an option. What a clever way to put this. Now, notwithstanding that, we're not even going to get into what to do for less than 1 centimeter nodules. I know Dr. Miyachi, Dr. Ito are in the audience, and I think Dr. Miyachi is going to speak about surveillance for low-risk thyroid cancer. So which thyroid cases mandate a total thyroidectomy, at least? Well, patients with multifocal disease, nodularity, undiagnosed in a contralateral lobe, any high-grade disease that requires postoperative radioactive iodine, such as aggressive pathology, large lesions, presence of multiple metastases, patients with nodal metastases, clearly, patients with evidence of extrathyroid extension, such as a vocal cord paralysis, invasion of the esophagus or trachea or larynx, and where it's technically impossible, such as the cases I showed you, to remove disease without performing a total thyroidectomy. Now, we have a little devil inside some patients, and that little devil, heretofore never been described or recognized, is that genetic driving factor that tells patients to get thyroid cancer. So that little devil is affecting the whole thyroid. So to do less than a total thyroidectomy in those patients, I believe, is doing those patients a disservice. So who are those patients? Well, these are patients who have received low-dose radiation in the neck, perhaps as a child for the treatment of acne, perhaps dental workers, clearly patients who were involved in the Chernobyl meltdown in the 1980s, patients from the Filipino community and Hawaiian community, patients with a strong family history of well-differentiated thyroid cancer, patients with syndromes such as familial polyposis, Cowden syndrome, and Pendred's. However, we must take into account the ability of the surgeon. If a surgeon is uncomfortable and lives in a remote area and can't do or is uncomfortable doing total thyroidectomies, clearly that surgeon's go-to operation should be less than a total thyroidectomy and ship off any patients that mandate total thyroidectomy. So at the end of the day, which thyroid cancer cases mandate less than a total thyroidectomy? Well, the favorable case, both biologically and anatomically, always taking into account the balance between operative morbidity and tumor biology. Again, let the punishment fit the crime. So what is the ultimate choice at the end of the day? Where do we absolutely or must do less than a total or a hemithyroidectomy? I would say small, solitary tumors that are proven, well-differentiated cancer with no neck nodes and favorable pathology. And even then, the evidence is not great, but I think that's the best we have. And we do a total thyroidectomy for all other well-differentiated thyroid cancers. Thank you very much.